Hello, good evening, everybody. Welcome to our inaugural education meeting for the Asia Pacific Leukemia Consortium. I'm Goyalti from Singapore. I'm also the lead for the clinical trials and also the director for APLC. On behalf of our newly formed APLC, we welcome all our members from the various countries represented within Asia Pacific. And as a start, I would like to give you a brief introduction into what our APLC is and how we came about. Can we have the next slide, please? Next slide. So why Asia Pacific and why leukemia? So a few of us met together and we discussed there's a need for actually a group to actually look into leukemia because there's a lot of very new advances in leukemia. But we also decided to include leukemia and related diseases, which essentially includes all the hematologic malignancies. So the focus is on leukemia, but we include other hematologic malignancies as well. And we are mindful that there are other groups that focus on other areas, so we will not overlap with them, such as the myeloma group and so forth. Why Asia Pac? Because I think we all know that Asia Pac is a very large population of the world, over 59%, very heterogeneous population. There's very good adoption of technology, relatively low cost, especially to do very excellent quality trials in clinical research. And there's a large number of proportions of AML, ALL, and unmet needs within Asia Pac. So with that, we decided to form the Asia Pac Leukemia Consortium. Next slide. And our mission statement is to improve the management of leukemia and related diseases in Asia Pac through the collective collaboration of valued partners and a targeted approach to bench bedside research and translation of real-world evidence and bioresources. Next slide, please. So the group of us met about 2 years ago, 2 to 3 years ago, and then we have discussed various programs and unmet needs as well we've discussed. And then we then decided to form the group, and various models of the group was discussed, either as an independent society or housed within one of the academic institutions. And we elected to house within an academic institution after deciding various choices, because I think we find we need to have a proper legal and financial setup to be able to do robust planning and trials. So after that, then we met, and the APEC legal entity was established within Singapore, within Singapore General Hospital. And then the 5 key research focus areas were actually discussed and established. And we also had a consensus on the constitution of the APLC. Then further than that, our first inaugural meeting with all our industry partners was in late November 2011. And the various working groups were established. So this is a brief overview of the timeline. Next slide. And these are our 5 focus areas: clinical trials, disease registry and repository. After subsequent meetings, the registry and repository groups were merged into one. Then we have education, and then we have patient advocacy and care. So these are our focus areas for APLC. Next slide. So within APLC, the core founding group divided ourselves into the various groups, and each of us took various key roles. So we have clinical trials for myself, we have Dr. Ng, Ashley Ng, Dr. Koh, and Dr. Lau for the disease registry and repository. For advocacy, we have Dr. Ng Su Chin from Malaysia. For education, we have Prof. Kim Jin Shok from my fellow co-chair for today. For the AML working group lead, AML includes MDS, we have Andrew Wei, our speaker for tonight. For the AL working group, or the lymphoid working group, we have Prof. Kwong from Hong Kong. And from the other related disease working group, we have Prof. Sukwon from Thailand. So these various key roles were assigned. Next. And then we started our formation of our core members. So we have members from various countries: Australia, China, Hong Kong, Japan, Malaysia, Singapore, South Korea, Taiwan, and Thailand. And this is a work in progress. We are just starting to form our core lead group, whereby we'll then start working on our various projects. Next slide. So with this, we have the contact information, and in case you want to need more information, please reach out to us either through email or through our website. And then we'll be reaching out with more plans for at the end of the year. We hope to have a full meeting, 2-day meeting, sometime towards the third quarter or fourth quarter of this year. So please look out for more information, and we may have more educational meetings where we will then open up to everybody. So with that, it comes to the end of my presentation. Now there's a slight switch around in the program because Prof. Wei was slightly delayed. So we will do the lymphoma session first. So with that, I'd like to introduce my fellow co-chair, Prof. Kim Jin Seok, to take over the session.
Good evening, everyone. This is Jin Seok Kim from Severance Hospital, Seoul, Korea. I'm working as an educational leader for APLC. Today, we will start the DLBCL session first. I'd like to introduce the Professor Davis. He is working as a professor of hematological oncology in University Hospital Southampton. He is a specialist for the treatment of lymphoma. He is now conducting a lot of clinical trial for malignant lymphoma. Professor Andrew Davis, please.
Thank you so much, Professor Kim, and all of the team in the APLC, and particularly Professor Go, for inviting me. I have been charged with talking about some updates in diffuse large B-cell lymphoma over the next 20 or 25 minutes or so. So I hope we have lots of time for interactive discussion, because of course this is a really exciting area for thought and for change in practice at the moment. So I just have a number of conflicts of interest that I just want to start off with. So I think our expectation of success in diffuse large B-cell lymphoma is high, and we recognise that patients that get into clinical trials do generally very well, and we expect maybe sort of 80% of those patients to be alive 2 to 3 years after initial diagnosis. Now, for very many reasons, of which you will all understand, overall survival in a real-world population, unfortunately, is disappointingly lower than that. And in fact, about 40% of our patients with diffuse large B-cell lymphoma are unfortunately going to be failed by our current approaches, with 2 to 3 year overall survival from population-based analysis of only about 60%. Now, we're quite good at being able to stratify patients with DLBCL, and we can recognize which patients are going to do well because they have few clinical adverse prognostic features, for example, as defined by the International Prognostic Index. And for those patients who have 0 or 1 risk factors, we are thinking about reducing therapy, and we're thinking about either giving 4 cycles of R-CHOP chemotherapy or taking at least a risk-adapted approach. For those patients who have multiple adverse prognostic features as defined by the IPI, so those with high intermediate IPIs and high IPIs, unfortunately their outcomes are poor, and just over about 50% of those patients are alive at 2 to 3 years. Now, layered on top of those clinical parameters is we can add information about some of the biomarkers we know. We recognize the cell of origin can define a group of patients who have an ABC phenotype that has a much less good prognosis, but also a group of patients that double express MYC and BCL2 proteins have a worse prognosis. And if you subdivide that group even further, those DLBCLs that have MYC and BCL2 translocations are also associated with a worse outcome. Now, over the last decades, we've tried to improve upon the outcomes with R-CHOP chemotherapy. And there have been a number of different approaches, but really stubbornly, we've been stuck at R-CHOP chemotherapy as our frontline standard of care, 6 cycles, 8 cycles, 6+2 rituximabs, really for the last 15 years or so. And the attempts have been to try and add additional chemotherapy drugs without success, to abbreviate the interval between R-CHOP chemotherapy, so R-CHOP 14 wasn't better than R-CHOP 21, to think about consolidating therapy with high-dose chemotherapy. Well, that maybe improved progression-free survival in high-risk groups, but didn't really improve overall survival. Maintenance, using different monoclonal antibodies to partner with your chemotherapy, and none of those seemed to have any clear impact upon outcomes. So there was a shift towards saying, well, look, we understand more about the biology of DLBCL. Why don't we do some trials that focus on the pathways that are dysregulated in DLBCL? And let's use a risk-adapted approach according to the cell of origin model and see if we can add an additional drug to R-CHOP chemotherapy to see if we can improve the outcomes. And there have been a number of studies, and this is just one of those, the Phoenix study, which looked at the addition of ibrutinib to R-CHOP chemotherapy. And you can see in the non-GC subgroup of DLBCL that this was not associated with any improvement in either event-free survival or overall survival. And there have been several other studies with lenalidomide, bortezomib, etc., that have shown a very similar result, which has all been really rather disappointing. And so trying to explain why this is the case and why hasn't it held up for the cell of origin model in diffuse large B-cell lymphoma? Well, I think we can think about it in a number of ways. I think, did we just select good risk patients? We recognize that the patients who get on clinical trials tend to be good risk, and also they tend to have a kinetics of the disease that allow a longer time from diagnosis to initiation of the study medicines. We know those patients who have kinetics where the disease is rapid and you need to start treatment very quickly from diagnosis, they do worse. And that's just really a reflection of the more aggressive biology of the disease. We may have taken too long to identify which patients were a certain cell of origin, and we may have just picked the wrong drugs. You know, we have these drugs that we think are ABC targeted, but perhaps they actually aren't as good as we think they are. I think probably the reason, however, is that what we didn't really understand was that there was a significantly greater degree of molecular heterogeneity that we hadn't recognized. And indeed, recent studies that have not just used transcription analysis, but also have built upon transcription analysis by analyzing the whole exome and looking at structural variants and looking at areas of copy number variations, have recognized that there's a great degree of heterogeneity in DLBCL. And that there are probably at least 4 different subtypes of ABC, there's probably at least 3 different subtypes of GCB. And if you look at the LymphGen model of diffuse large B-cell lymphoma, which was pioneered by our colleagues in the National Cancer Institute, there are 7 different molecular subtypes of DLBCL. And these are great, 7 subtypes, excellent. It really defines quite nicely a group of diseases that have common genomic aberrations, and then potentially therefore common patterns of molecular aberrations and therapeutic targets. And some of these may confer difference in prognosis or predictive factors, which I'm going to talk about in a bit. But this is complicated. It takes time to employ. At the moment, we can't do this in a clinically meaningful time frame. And the other problem with this method of molecularly classifying DLBCL is that actually 40% of patients fall outside these 7 defined subgroups. And for us to try and do clinical trials in a group of DLBCL that may be only representing about 5% or 2% of all DLBCLs is really difficult in terms of molecular targeting and therapeutic targeting. So I think we've got a lot of work to do before this becomes prime time. So not only have we better understanding of the biology and better molecular classification in DLBCL, I think we're in a really fortunate place in terms of the range of novel therapeutics that are starting to reach the clinic, and some of these are reaching marketing approval. We have a number of drugs that are being investigated that target pathways that are dysregulated in DLBCL. We have drugs that target pathway aberrations in and the microenvironment, and we have drugs that target cell surface antigens, and then we have both naked antibodies, antibody drug conjugates, and of course we've got bispecific antibodies, and all of these are just jostling to find the right place in the management of DLBCL. So I have to start my discussion about new therapeutics really with polatuzumab, because this is something that we've got to really consider. And I just want to have a quick look at the data. So polatuzumab is an antibody drug conjugate. The antibody targets a component of the B cell receptor CD79B, which is common to malignant B cells and also to normal B cells as well, or at least a range of B cells. The antibody takes with it a cytotoxic payload, MMAE, or monomethyl auristatin, which is the same cytotoxic payload as we use in brentuximab vedotin, and it's linked to the antibody by a cathepsin B sensitive linker. So when the antibody drug conjugate binds to the CD79B on the surface of the B cell, it's internalized, and within the lysosome acidic pH, the cathepsin B linker is cleaved, releasing free cytotoxic, which goes on to cause microtubular disruption and apoptosis cell death. And as a single agent or in combination with rituximab, polatuzumab is a really effective drug but has low CR rates. So you know, in the relapse and refractory setting, a randomized study, albeit very small, adding polatuzumab to bendamustine and rituximab improved complete response rates in transplant ineligible patients and resulted in significant improvements in both progression-free survival and overall survival. And we've become increasingly familiar with using polatuzumab, bendamustine, and rituximab in our transplant ineligible patient population. Now, in the UK and in Germany, what we're asking whether polatuzumab is of benefit in combination with R-ICE chemotherapy in the patients group that are transplant ineligible, and actually can we increase the amount of patients who become PET negative by adding polatuzumab. We're doing that in a randomized fashion. But of course, really the space that everybody wants to is to adopt their novel therapy in the frontline setting. And I'm sorry, I've lost my slide there. But essentially, the addition of polatuzumab to R-CHP chemotherapy, so removing the vincristine, because of course you're delivering a microtubular inhibitor, has been shown in a phase 1b study to be safe and highly effective. And of course, that led to a large phase 3 study, the POLARIX study that we've seen presented just a couple of months ago. And simply, patients were randomized to receive standard of care R-CHOP chemotherapy for 6 cycles with 2 additional rituximab, or polatuzumab with R-CHP chemotherapy for 6 cycles. And this was a group of patients who had an IPI score of between 2 and 5. Now, the patient demographics is that 880 patients recruited into the study. Of course, they were well matched between them, and the majority of patients who entered the study had an IPI score of 3 to 5. Now, the safety profile of adding polatuzumab to R-CHP chemotherapy was not significantly different from the safety profile of R-CHOP chemotherapy. And I think we're all very interested in that. There was no greater rate of neuropathy. There was no significant difference in the rate of hematological toxicity and the rate of infective episodes. So what this did mean was that you could add polatuzumab safely to R-CHP chemotherapy without much in additional toxicity on top of conventional R-CHOP chemotherapy. And of course, the primary endpoint of the study was investigator-assessed progression-free survival. And what this demonstrated was that there was a significant improvement with a hazard ratio of 0.73, favoring the polatuzumab containing arm. So this basically meant a 27% reduction in the risk of progression and death through the addition of polatuzumab, or the substitution, I should say. Now, all of these patients have been followed up for 2 years. I think we all consider that to be a very important event in the DLBCL follow-up, and the absolute difference between arms was 6.5%. So a significant difference between the two arms. However, there was no difference in overall survival, and you can see that the two curves completely overlap each other, which I think is vexing given the amount of follow-up time that we have had, and given the fact that we think event-free survival at 2 years has traditionally been considered a surrogate for overall survival. So progression-free survival advantage, no overall survival advantage, similar safety signal. Now, there's quite a lot of heterogeneity in the benefit, and this is a complex forest plot, and so my next slide, I'm just going to pull the red boxes round those subgroups that I think are really interesting. We see that there was benefit in the over 60s in subgroup analysis. The benefit in subgroup analysis was confined to those people at the high IPI end, so IPI 3 to 5, those patients who didn't have bulk, and interestingly, in those patients who had an ABC phenotype. Now, there's no reason why an ABC phenotype should necessarily be associated with an improvement over GCB, particularly in the relapse studies where it seems to be regardless of the cell of origin model. So we see some significant heterogeneity in the effect from adding polatuzumab to R-CHP chemotherapy. So I think we've all got to think quite hard as users and our regulators and our funders about adoption of this positive study into our practice. And actually, I would also say that the exposure to second-line chemotherapy was greater in those patients treated with R-CHOP chemotherapy than those patients treated with R-CHP pola. And I think that's relevant because we know the stakes are high in patients with relapsed and refractory DLBCL in terms of the economics and the toxicity of second-line therapies. Now, I'm just going to move on just in the interest of time. So we have started to see, rather than just a generic agent adding to R-CHOP chemotherapy, we've started to see some attempt to try and focus therapeutics upon the molecular origin of the diffuse large B-cell lymphoma. And we've been doing some work looking at the addition of acalabrutinib to the N1s and the MCD phenotype. But this study that came from the group in Shanghai was an interesting attempt to define which molecular category a diffuse large B-cell lymphoma tumor belonged to, and then add drugs to R-CHOP chemotherapy. Now, this was done in a fairly simplistic way with an 18-gene mutational panel in an attempt to try and put people in different molecular subgroups. And for example, those patients who had ABC tumors driven by chronic active B-cell receptor signaling in the MCD group, ibrutinib was added to R-CHOP chemotherapy. For drugs that will have TP53 mutation, a hypomethylating agent was used. In another group of patients, an HDAC inhibitor was used, or lenalidomide. And this was examined in a small study, underpowered study, comparing those patients who had R-CHOP with an additional agent to those patients who didn't have an agent added to R-CHOP chemotherapy. And quite surprisingly, for all subgroups of diffuse large B-cell lymphoma, there was a benefit in terms of complete response rates, in terms of the R-CHOP plus X arm, and also there was a clear improvement in progression-free survival. And I think this study is important because it's our first attempt to try and define molecular subgroups and in some way try and modify those molecularly defined genomic subgroups by the addition of other drugs. So watch this space in terms of molecular classification. Now, we've also got a whole range of other drugs that we are starting to examine in diffuse large B-cell lymphoma. There are other antibody drug conjugates, such as Lonca-T, which targets CD19 on the surface of the malignant B cell and carries with it a different type of cytotoxic payload, which is a PPD dimer. This has a different toxicity profile to MMAE, and patients may get problems with LFT abnormalities, photosensitive rashes, and edema or effusion. But as a single agent, it appears to be quite effective. We also have another CD19 naked antibody this time, which is a humanized anti-CD19 with enhanced FC activity. So tafasitamab is able to enhance both directly ADCC and also apoptosis. And when used in combination with chemotherapy in relapsed and refractory DLBCL, it has response rates that near 60%. And also some of those responses have gone on and proven to be durable. And now tafasitamab is being investigated in randomized studies in the frontline setting of R-CHOP, lenalidomide, and tafasitamab. So the drugs in combination in the frontline setting are starting to grow. Now, of course, we're very excited about bispecific antibodies in diffuse large B-cell lymphoma. Those that target both CD20 on the surface of the B cell and CD3 engaging the T cell are the common and most later stage of clinical development, and there are 4 of those, and they have some different properties. They have different numbers of epitopes that bind, they have different formulations of delivery, subcutaneous or IV, and they have different mitigation strategies to reduce the risk of cytokine release syndrome. But what we do recognize is that probably about half the patients with relapsed and refractory diffuse large B-cell lymphoma have benefit, and the majority of these patients have very durable benefits as well. What's very interesting is some experimental work that we've seen in using a bispecific in the front-line setting, and therefore removing immunochemotherapy for older or comorbid patients. And actually, instead of giving immunochemotherapy, actually giving these patients, where we often find it difficult to deliver immunochemotherapy, we're giving these patients a bispecific. And this study of mosunetuzumab in frail patients, those over the age of 80 or with comorbidity, had overall response rates of 64%, many of which were durable, using a regimen that's absolutely free of chemotherapy. This had a low rate of cytokine release syndrome. And we've seen that bispecifics are being used in the setting of treating patients who've relapsed after CAR T-cell studies, and there are now ongoing studies of adding a bispecific to R-CHOP chemotherapy to improve the outcome of R-CHOP chemotherapy. Now, whether that will work or not, I don't know, because of course the chemotherapy may suppress the T-cell effector function. So it'll be interesting to see what direction of travel happens with this in the sequencing of bispecific antibodies. Now, in the last few minutes, I think it's really important that we have some discussion about another way of engaging T cells via the CAR T-cell product. And globally, there are now 3 CD19 directed CAR T-cell products that have been approved. There's variation in approval across different territories. And what we can see from the pivotal data, largely from these studies, is actually that in a subset of patients who do have CAR T-cells in the 3rd line plus setting, probably about 45% of those patients will have long-term durable benefits. And I think we saw at ASH this year this really important 60-month follow-up of the ZUMA-1 study. So these first 101 patients treated with axi-cel followed up for 5 years. And we recognize that 43% of those patients are alive at 5 years. So these were 3rd line diffuse large B-cell lymphoma patients. And so that's clearly changed the whole paradigm of approach for our patients. And for those patients who received CAR T-cells and then were event-free for 2 years, over 90% of these patients are alive at 5 years. So I think if you're lucky enough to be able to have disease kinetics that's suitable for manufacturing of CAR T cells, and that you're fit enough to get through some of these toxicities, ultimately many of these patients have a very good outcome. And we can see the data of pivotal trials is being reflected in the data that's coming out now from real world experiences. And this is just data from the UK, where we have a panel approving everybody across the country for CAR T cells, and therefore assuring that there is equity of access. But very briefly, our event-free survival is about 40%, and exactly what we would expect in the real world. Now, of course, CAR T cells have their own unique toxicities. We recognize that there are short-term toxicities in terms of cytokine release syndrome and the neurological toxicities, which we're getting better at managing by using steroids and early use of steroids, tocilizumab, so in some places, using IL-1 antagonists as well. But what we do recognize, as the patients return back from their CAR T cell centers to local practices, is that many patients have long-term cytopenias and also have long-term B-cell aplasia. We recognize from the long-term ZUMA-1 study data that 40% of patients are still having IVIG infusions in long-term follow-up. Now, of course, we've seen at ASH this year the publication of data comparing CAR T cells, this time in the second line compared with the third line, and being compared to standard of care reinduction therapy followed by high-dose chemotherapy and stem cell rescue. So second line CAR T cells. And we saw 3 studies presented at ASH this year. Now, importantly, the ZUMA-7 trial demonstrated a hazard ratio of 0.39, so a significant improvement in favor of the CAR T cell over the standard of care group of patients. Now, these were highly selected patients. All of them had been diagnosed within 12 months, so they were the most refractory of patients, and also these patients were not patients who needed bridging therapy or had any evidence of organ compromise. So this is a selected group of patients demonstrating the effectiveness of CAR T cells over high-dose chemotherapy. And this was didn't show any difference in overall survival, and that's probably because many patients switched over to receive CAR T cells in the third line setting. Now, this result was validated by the TRANSFORM study result, this using lysocaptogene, which was also significant from an interim analysis. But the Belinda study that compared Tisagen, so tisagenlecleucel, to standard of care showed no difference in outcomes. And that's probably because the kinetics of delivery of the CAR T cell was so much longer, a median of 56 days compared with just 21 days in the group of patients in the axicell arm. So I think that we can see some change in practice, but this is going to be restricted to those patients who relapse within 12 months of initial diagnosis. So this is not going to completely replace the autograft, but I think it's going to be significant for our most high-risk group of patients. The difficulty is by pushing CAR T cells up into the second line setting, however, is that there's going to be problems for the delivery of subsequent therapies for our groups of patients, because we recognize with the cytopenias, treating patients who relapse after CAR T cells is really challenging therapeutically. And we've seen some interesting outcomes with lenalidomide in the post-CAR T cell setting, perhaps are bipolar, and I think there's some data to suggest that bispecifics might be of interest. But I think giving conventional immunochemotherapy is really difficult in patients who relapsed post-CARs. So I just wanted 1 minute at the last end to say, where do I think our direction of travel is in diffuse large B-cell lymphoma? Well, we've seen some exciting data with polatuzumab. We've seen some exciting data with CAR T-cell therapy. They appear to be agnostic of the cell of origin and the molecular modeling in diffuse large B-cell lymphoma. But I think what we need to do is we need to do clear experiments where we can integrate knowledge and pull out both the good and high risk patients early. So I think what we need to do is we need to understand the baseline risk much better, first of all, for our patients by looking at the clinical parameters and the molecular factors. And then we need to monitor how patients' responses change during induction R-CHOP chemotherapy by interim PET scanning and potentially by monitoring dynamic changes in cell-free DNA. So that those patients who are destined to do very well with R-CHOP chemotherapy continue to receive R-CHOP chemotherapy. And for those patients who need different treatments, they can be pulled out early and be potentially subjected to other therapies such as CAR T cells or potentially bispecific antibodies. And the ZUMA-12 study that was presented at ASH this year was the first attempt to do that. This took an already high-risk group of patients with double-hit lymphoma or high IPI. They had 2 cycles of R-CHOP chemotherapy, and if they had an interim PET scan that was positive, so the highest risk of patients, they went off then to have CAR T cells with the axi-cell regimen. And the overall response rate here, the complete response rate was 78% of patients who went on to get CAR T cells, and many of those responses have proven to be highly durable. So this is a proof of principle that you can identify your bad actors early and intervene quickly. So I think in summary, I think we've got a lot of exciting new options in diffuse large B-cell lymphoma, that some of those have already demonstrated their benefit in the relapse setting and now are starting to demonstrate their benefit in the frontline setting. What we need to do is get better at using molecular and dynamic methods to identify those risk patients so that we can intervene early. Thank you so much for listening. I look forward to a lively discussion. Thank you.
Thank you, Andrew. Very fantastic lecture. First, can we show the polling question to the audience? Yeah, we have one question to the audience. Please select the best answers. The question is, you already showed the Polaris trial data. How do we select the frontline therapy for newly diagnosed DLBCL? The first is R-CHOP, still R-CHOP. The second is Pola-R-CHOP for all patients. The third is Pola-R-CHP for selected patient, especially ABC subtype. The fourth is, yeah. Please select the appropriate one. We will wait a couple of seconds. Okay. Okay, enough.
It's changing fast.
Yeah, as you can see here, many audience select the Pola-R-CHP for the selected patient. You know, the polatuzumab is relatively high cost, I think. So many audience have a lot of concern about the cost, I think. The efficacy is quite good. However, the cost will be problem, I think.
So I think this study presents a number of concerns in terms of the interpretation of it. I'd be really interested to know people's views on this. But I think that here we are, a study that shows a progression-free survival advantage, but not an overall survival advantage.
Yeah, right.
In a curative malignancy is a little bit of an odd thing. There is obviously clearly heterogeneity in the outcomes. So although I selected to you the groups of patients that did well in the subgroup analysis, and we said ABCs, older patients, IPI 3 to 5, non-bulky, etc. One of the subgroups that I dared not mention that didn't do very well from the addition of polatuzumab was female patients, and the effect was also in male patients. So the question is, you know, are you going to deny half of the patient population because of subgroup analysis? And I don't mean for any reason that you would, but what I would say is that I think we have to be very cautious about selecting our patients based upon underpowered subgroups, and I would not be keen to see that polatuzumab was restricted to subgroups which, although pre-planned to analyze, were not powered at all. So I would be very keen to use it for everybody who was included in the trial, and that means everybody with the IPI 2 to 5.
Okay. As you can see here, many audience select the PULA RCHP for selected patient, but still many audience still select the R-CHOP standard regimen. Can you show me some question from audience? Yeah. I will start the question about the polatuzumab. Is there any predictive marker for expecting the outcomes of PULA CHP? It is quite a difficult question. As you know, considering the mechanism of polatuzumab, I cannot understand why the PULA CHP regimen showed better outcome in the ABC type.
I think you're absolutely right. So in the study of bendamustine rituximab and polatuzumab, the outcomes were the same, regardless of whether you were ABC or GCB or you didn't know. The other biomarker that sometimes people ask is whether it's related to the degree of expression of CD79B on the cell surface, and it seemed from that study that there was no difference. So, you know, it was considered that polatuzumab was a drug that worked irrespective of the cell of origin model. So I think looking at the data from the polatuzumab, where there seems to be a benefit in the ABCs, it is a bit of a strange result that I can't clearly explain from a biological reason. So I would say to you, at the moment, there is not a biomarker to predict response to polatuzumab, and I can't say to you mechanistically why the ABC subgroup seems to work better. But you know, the stuff is going on at the moment in terms of mutation analysis in the CD79B receptor and a load of translational work to try and understand this more. But I think it's a really good question.
Yeah. Please show me the next question. Yeah, we have a lot of question about CAR-T. You already showed some CD19 monoclonal antibodies for relapsed refractory DLBCL. Can you use CAR-T, CD19 CAR-T therapy for patients who received previously anti-CD19 monoclonal antibody?
So I think that's a really good and important question. I don't know who asked it, who was anonymous, but I think it's really important. And I think we have a lot of work to do in terms of the sequencing. And the reason we're worried about this is because obviously we've observed in patients who've relapsed after CAR T cells, selection of clones that are CD19 negative. So theoretically, if you're going to push your CD19 directed therapies earlier up in your disease course, then you may well have a group of patients who lose CD19 expression at relapse, and therefore you lose the target for the CAR T cells that are commercially available. Now, of course, there's not very much data for this. The number of people who've had CD19 directed therapies and then gone on to have a CAR T cell is relatively limited, but there was an analysis performed by a group in the UK, actually, the UCLL group, who gave people long developing the CD19, the LonCa-T monoclonal antibody drug conjugate, I should say, and then went on to look at CD19 expression at the time of relapse. And they saw that there was no loss of CD19 expression post the CD19 antibody drug conjugate. And many of these patients did go on to have CAR T-cell therapy. Now, actually, if we think about using a CD19 directed therapy even further up, so maybe in combination with R-CHOP chemotherapy at diagnosis, does that mean that there's a greater potentially larger pool of patients who might be CD19 negative at relapse? So I think we have to be really careful, and I think we have to understand very carefully the sequence of therapeutics in DLBCL. And what I will say to you is that it plays to the point that it's really important for us to perform biopsies at relapse in our patients. So I think lots of work to be done on sequencing. At the moment, no evidence there is loss of CD19 expression post CD19 antibodies, but I think we need to be really careful and mindful of this. Some of the newer CARs that have sort of target CD19 and other antigens such as CD22 might be ways of circumventing this.
Yeah, okay, very good answers. You already mentioned about the negative impact of bendamustine before starting CAR T-cell therapy. Can you explain in detail?
Yeah, of course. So what we recognize is that bendamustine is really quite toxic to T cells. And of course, what you want in CAR T cells is you want abundant numbers of healthy, fit T cells for your transfection. So I think there is a concern in exposing patients to bendamustine or in the combination of RB polar, for example, prior to apheresis of T cells for CAR T cell manufacturing may compromise the fitness of the T cells that you eventually return to the patient. So as a general consensus, we try and avoid bendamustine prior to any apheresis. Now, that's important. Sometimes your options are a little bit limited. We're increasingly recognizing for CAR Ts in mantle cell lymphoma that there are patients who have previously been exposed to bendamustine. We tend to use RB polar as a bridging treatment. So once we've done the apheresis, we give them RB polar to buy time during the manufacturing, because the manufacturing can be quite long, sometimes in Europe, because this is all being done largely in the States. So I will say to you, if you've got a patient where you think you might want to get to a point of CAR T cells, please avoid bendamustine. And we can see from the data of progressively using T cells from third line to second line to front line with the T cells to become CAR Ts, we get better T cells, we get better response rates, we get better T cell expansion if we use use T cells that have less chemotherapy exposure. So try and keep your T cells away from bendamustine.
Yeah, thank you. As you know, auto stem cell transplant is still standard option for the first relapsed DLBCL patient. In case of the relapse after auto transplant, how do we select an appropriate therapy between CAR T therapy and allogeneic stem cell transplant?
Great question and really important. And I think for CAR T cells, because of CAR T cells, there has been a reduction in favor of allogeneic transplantation because of CAR T cells. We recognize that here we are with CAR T cells, we've got an effective third line therapy. And as I said, 43% of patients who are selected for CAR Ts and have a reinfusion are alive 5 years afterwards. So I think that's a very important number. And actually the long-term comorbidity from CAR T cells is relatively modest once you get past that kind of first year of cytopenias and those very acute toxicities. The TRM from CAR T cells is also very low. And so you have to contrast that with allogeneic transplantation, where you first of all have to get your patient into a stable remission. That's quite difficult in terms of the kinetics of allogeneic transplantation, for the time for the patient to remain in remission. We still unfortunately have too higher TRMs from allogeneic transplantation. We also have chronicity of comorbidity that may go on for really quite some time. So for my mind, I see that CAR T cells trump allogeneic transplantation in relapse post-autograft. I also see that CAR T cells trump allografting in terms of the better toxicity profile, I would say that there clearly is less use of allotransplantation because of these key facts and the durability of benefit from CAR T cell therapy.
Thank you. It is quite a difficult question. You gave best answers. The last key question is about the circulating cell-free DNA. Do we have used cell-free DNA in the treatment of DLBCL?
I think that's a great question and something to look and keep on the horizon. I consider it still an experimental approach, but one that really we're beginning to growingly recognize has clear value. Okay, so cell-free DNA at baseline, the levels correlate to prognosis and identification of clones that are rapidly cleared and are sustainably cleared after R-CHOP chemotherapy are absolutely prognostic of benefit. So we can identify after one cycle of R-CHOP chemotherapy, those patients who've had log falls in ctDNA level are pretty much going to do well, and those patients who have climbing levels are pretty much going to do poorly. Now, there's still a lot of work to be done with this technology in terms of standardization of methodologies, validation of methodologies, cross-lab validation as well, so that we can approach this in a standard way, and that the readout from my lab can be the readout the same from your lab, so we can internationally recognize this. We're not there yet. We haven't really validated this in prospective studies yet, but I think it's really exciting. I think the data in terms of response assessment is interesting, the data in terms of MRD use of ctDNA, and of course the data that we saw presented at ASH looking at ctDNA in the peripheral blood and looking to see in helping us with diagnosis of primary CNS lymphoma and potentially trying to identify patients who are at risk of secondary CNS lymphoma are all really exciting. So my advice to you is to watch the ctDNA space really closely to look at the impact upon this exciting technology.
Thank you, Andrew Davis. It is quite a good discussion. I hope today's lecture and discussion will be helpful for understanding the pathophysiology and treatment of DLBCL to the audience. I will hand over the chair to the Yotego.
Thank you.
Thank you.
Thank you very much, Prof. Kim and Prof. Davis, for a very exciting session and discussion on DLBCL. So let's move on to the next session. For those of you who came in late, we had a slight switch in program because Prof. Wei was slightly delayed. I hope that this doesn't impact too much. So our next session will be on acute myeloid leukemia updates. And it's giving me great pleasure to introduce our next speaker, Prof. Andrew Wei, who has recently moved to the Peter MacCallum Cancer Centre and Royal Melbourne Hospital. Prof. Wei is the chairperson of the Australian Leukemia and Lymphoma Group. He's pioneered many studies such as SLODAC, ISA, and many other cutting-edge research, and is a very well-known figure in the world for myeloid leukemia and MDS. He's also our lead for our myeloid lead for our APLC. So to give us updates for AML from ASH, welcome please, Andrew Wei.
I wanted to thank the organising committee for asking me to give today's presentation. And let me just paint the picture that up until a few years ago, from the early inception of chemotherapy for hematologic malignancies, for almost 60 years, the proportion of patients over the age of 70 who comprise almost 50% of the AML family essentially had very poor outcomes, and the only treatments we really had were low-dose RSC with responses of less than 20%, median survival of about 4 months, and azacitidine with median survival under 12 months and response rates of about 28%. So this is what we had to work with for many, many decades. And so hopefully that puts some of the presentations tonight into some perspective. These are my disclosures. And so today I'm going to present a few different studies. First, with respect to a practice-changing study, a negative randomized controlled trial, some updates on some approved therapies, and also some promising new therapies in development. So first of all was the AGILE study, which is a global randomized phase 3 trial, which was seeking to ask the question, would a targeted IDH1 inhibitor called ivosidenib in combination with azacitidine, which I mentioned before was really a palliative option for older people, could this make a difference for IDH1 mutant patients who are unfit for intensive chemotherapy in the frontline setting, who make up about 5 to 10% of older patients with AML. And so, fortunately, at the moment, we already have a fairly good therapy in Ven/Aza. And as you can see here, for both IDH1 and IDH2 mutant AML in older unfit patients for intensive chemotherapy, that Ven added to Aza improves the response rate by more than 7-fold in both IDH1 and IDH2 mutant AML. Are there any marginal differences between these two extraordinary outcomes? Maybe. You can see the IDH1 response rate is about 20% lower than IDH2, and you can see that the survival curve tends to drop off a little bit in the IDH1 subgroup compared to IDH2, where there appears to be a plateau, but clearly more numbers and more follow-up are required. But on this backdrop of already extraordinary improvement in IDH mutant disease with venetoclax, we now have this AGILE study, which really challenges what should be the standard of care for this subgroup of patients. So AGILE was a randomized trial with a plan to enroll 200 patients with a placebo control arm, and the primary endpoint was event-free survival. Now, at an interim analysis after enrollment of 146 patients, the study was prematurely closed by the IDMC because of an overwhelming efficacy benefit in favor of ivosidenib. If we look at the baseline study characteristics, you can see they were relatively well balanced. Definitely older people, median age 76, and about 1/4 had either secondary AML or poor cytogenetic risk. You can see that the combined response rate, CR and CRh, for ivosidenib in combination with Aza was about 53% compared to 65% for IDH1 mutant AML with Ven/Aza. Second, you can see that the true CR rate was 47% compared to 28% for patients who received Ven/Aza, and you can see miles better than patients who received azacitidine alone. One interesting factor, however, was that the median time to response was 4 months, which was considerably longer than what we experienced with Ven/Aza, where responses are achieved much more quickly. And so the conclusion is that although responses are similar, responses are slower, but true CRs perhaps higher with this combination. Interestingly, if you look at the patients who did achieve a hematologic response, IDH1 mutation as measured by digital PCR was cleared in over 50% of patients, which I think is very impressive. If you look at the primary endpoint of event-free survival in the intention to treat population, you can see that there was an improvement in EFS in favor of ivosidenib. Why do these curves look so strange? The reason for that is events were defined as failure to achieve a response by 6 months, relapse, or death. And so if you fail to achieve a response by 6 months, patients were recorded to have an event on day 0, hence the steep drop on the day 0 baseline. However, if you look at the overall survival, which, as I mentioned, was not in fact the primary endpoint of the trial, you can see that ivosidenib improved overall survival by almost threefold, as you can see here, 24 months compared to 8 months without the addition of ivosidenib in patients with IDH1 mutant AML, and over 50% reduction in the risk of death, and incredibly significant p-value. So clearly this trial is a game changer, and that's why I've put this down as a practice-changing study in AML. You can see that the safety profile was also encouraging, no substantial increase in the rate of febrile neutropenia, nor infections, and with a differentiating agent, clearly important to realise that differentiation syndrome does occur in some patients that requires monitoring, and there was a QT signal which is well known for ivosidenib, which is, I think, ultimately manageable with appropriate monitoring. The next study, which was hoping to make a practice-changing impact on the field of AML, was called the LACE-WING study. What was the LACE-WING study? This was another phase 3, however, not a placebo control, but an open label randomized study, and this time targeting a different subgroup of AML with FLT3 mutant disease, again, for this older, unfit population, unfit for intensive chemotherapy. What do we have now? We have Ven/Aza. And you can see here in FLT3 ITD AML, even though the response rate with Ven plus Aza is marginally improved compared to Aza, you can see that the survival analysis in this post-hoc subgroup analysis, with all the caveats associated with it, don't particularly look promising. So the LACE-WING study was trying to address this. Originally, it set out to have a 3-arm study comparing gilteritinib plus Aza, the standard of care, versus Aza as the control arm. As I mentioned, an open label study, and overall survival was intended to be the primary endpoint. However, recruitment to this study was difficult, and so the gilteritinib only arm was dropped. And so today we're presenting mainly the 2 arms, gilt-Aza versus Aza alone. With respect to patient characteristics, you can see that almost the vast majority of patients had FLT3 ITD alone, and you can see that the allelic ratio was at least 0.5 in almost half the cases, indicating that most of these patients had loss of heterozygosity and hence a very ITD dominant disease. It was interesting that this is often a problem with non-placebo controlled studies, where patients who go off treatment in the control arm often receive available therapies which can sometimes confound the study result. And so you can see here in the Aza control arm, there were more patients that received subsequent therapy, and you can see here substantially more people that received subsequent therapy that involved a FLT3 inhibitor, which was the subject of the randomization. And you can see here that patients also received gilteritinib off therapy. Despite that, you can see that when we look at the response rate, that there was a more than doubling of the response rate with the addition of gilteritinib to Aza in patients with FLT3 mutant AML. So did this convert into a clinically meaningful benefit in terms of survival? You can see here that the overall survival curves very much overlap, with no clear space between gilteritinib plus Aza versus Aza alone. So did subsequent therapy impact on this result? If that was the case, we should see an improvement in event-free survival, because subsequent therapies would not be accounted for by that type of analysis. However, you can see that gilt-Aza versus Aza in an event-free survival analysis still did not produce an improvement in outcome, telling us that gilteritinib alone in combination with Aza is not the answer for frontline therapy of FLT3 mutant patients in older age groups. So where to now for FLT3 inhibitors in older people? many groups are looking at the possibility of triplet therapy with the addition of FLT3 inhibitors plus Ven/Aza, and I will talk about a triple therapy later on in my presentation. What about some updates on approved therapies? We know that oral azacitidine has been shown in a randomized study to improve survival in patients in first remission after intensive chemotherapy. And the question with respect to this abstract, which was presented at ASH, was to ask the question, what were the rates of long-term survival at 3 and 5 years with longer-term follow-up, now with almost 52 months of median follow-up with this trial, looking at oral AZA versus placebo in first remission after intensive chemotherapy for patients aged 55 years or over. You can see at 3 years, the absolute increase in survival with the addition of oral AZA was almost 10%. And at 5 years, the absolute increase in survival with oral AZA was 7%, and the curves do not touch. So the next question was, what were the characteristics of these longer-term survivors receiving oral AZA? And so you can see here, the line is drawn at 3 years, and you can see that patients in the long-term survivor group had a lower chance of having poor cytogenetic risk, a higher chance of having NPM1 mutation, and also that 23% of patients had this long-term survival despite not receiving any consolidation therapy. So these patients got into remission with intensive therapy, no consolidation therapy, onto oral AZA, and 1/4 have survival beyond 3 years. You can see that despite 35% of patients being MRD positive at study screening, almost 3/4 of these patients who had long-term survival had clearance of their MRD, and that the proportion of patients achieving MRD response with oral AZA was 37% compared to 19% in patients who received placebo. The next study update was in patients with Ven/Aza as a subgroup analysis of the VIALE-A trial, which looked at Ven plus AZA versus placebo plus AZA. Obviously a pivotal study which has been previously published in NEJM, but the question with this particular abstract was, what was the outcome of patients with poor risk cytogenetics? Because we know that has been a major stumbling block for all types of therapy used to date, including non-intensive therapy and also intensive chemotherapy. So if we look at this poor risk cytogenetic group and divide it into patients who have P53 mutant or non-mutant disease, this presentation was by Dan Pollier, you can see that with respect to Ven/Aza, that responses were improved regardless of the P53 mutation status, but obviously lower amongst patients with P53 mutant disease compared to patients receiving AZA. Now, what was really extraordinary about this abstract was that if you look at patients within the poor risk cytogenetic group who received either Ven/Aza or AZA alone with P53 mutant disease, you can see no difference whatsoever with the addition of venetoclax. However, if you had poor cytogenetic risk and you did not have a P53 mutation, you can see a lot of daylight in the survival outcome with the addition of Ven compared to AZA alone. What was even more interesting, I thought, was that if you had Ven/Aza, despite having poor risk cytogenetics, your median survival was very similar to patients that had intermediate risk cytogenetics, as long as you didn't have a P53 mutation, with a median survival of almost 24 months compared to 19 months for those with intermediate cytogenetic risk. Let's move now to some promising new therapies that were presented at ASH. The first one is the menin inhibitor story. We know that many groups have been trying to interrupt the MLL signaling pathway for many years with a variety of agents, including BET inhibitors, really to no avail. We know that MLL fusions are linked to the gene, their target genes by menin, and the question was whether a specific inhibitor of menin could alter the outcome of patients with either MLL fusions or NPM1, which putatively also relies upon menin for its engagement on target genes. And so this is a presentation of a first-in-human phase 1 study of the menin inhibitor SNDX-5613 presented by Eton Stein. So you can see in a traditional phase 1 study, relapse refractory patients heavily pre-treated, that the overall response rate was 55%, with complete responses being observed in about a quarter of patients. And very similar profile, regardless of whether the patients had MLL fusions or NPM1 fusions with respect to the combined CR/CRh rate. What I thought was really interesting was 2 points. Firstly, for patients that did achieve a remission, that the MRD clearance was almost over 90% in these patients. So not just responses, but really deep responses to the point of MRD clearance, which was quite extraordinary. And furthermore, of the 12 patients that did have a response, 6 had a response duration of more than 6 months. And we're talking a tablet in a poor risk AML, multiply relapsed after intensive and other therapies. So I think as a single agent, this is looking like a very bright future for menin inhibitors. And it's no wonder that there are many other menin inhibitors all competing to try to be first into the registration space for this subgroup of patients. You can see that the only liability of SNDX-5613 was a QT signal, which in fact was dose limiting and has resulted in basically identification of a maximum tolerated dose based upon this issue. And there are other menin inhibitors which perhaps don't have this liability. So it'll be interesting to see what will be the characteristics of the final approved drugs should one make it that far. Another really interesting and intriguing therapy is magrolimab, which is an antibody which targets CD47, which is a don't eat me signal. And when CD47 is blocked, it induces macrophage engulfment of target cells. And this study, led by Naval Dava from MD Anderson as an investigator-initiated study, was asking the question, what would happen if you added magrolimab to Venaza for newly diagnosed and relapsed refractory AML? The key benefit of magrolimab, many people believe, is the potential to target the most difficult subgroup of AML for which we don't currently have an effective or proven therapy, that is P53 mutant disease, which I've already told you, Venaza does not seem to make a long-term impact on. When you add magrolimab to Venaza, small numbers, but you can see that the response rate is almost 90%, with a true CR rate of 64%. And so, although very early days, it's intriguing to ask the question, is this potentially the major breakthrough for P53 mutant disease that we've been waiting many, many decades for? With respect to registration pathways, in AML, there is currently a study of Venaza versus magrolimab plus Aza. And obviously, this trial has led to a new study being developed of the triple therapy, Venaza plus magrolimab versus Venaza. Most people will also know that unfortunately this study is, and all the magrolimab studies in AML are currently on hold because of an early signal of safety. Hopefully this will be reviewed favorably by the FDA and the holds removed. Coming back to FLT3 mutant AML, this was a study done by our group in Australia, looking at the possibility of new triplets in older people to try and target mechanisms of resistance. We know that venetoclax-based resistance in non-adverse AML is commonly driven by kinases, and in poor risk AML, commonly driven by P53 mutant disease. So we designed 2 triplets, one for non-adverse and one for adverse risk disease. In the non-adverse, we combined low-dose RSC plus Ven with midostaurin to target kinases, and with an HDAC inhibitor, prosinostat, to target P53 mutant disease. You can see that the combined response rates were pretty good, despite small numbers in this dose-finding phase. The key issue, however, was that we combined our triplet in a slightly different way to other groups. Rather than starting the third drug on day 1 in combination with venetoclax and low-dose RSC, we started it after the completion of the low-dose chemotherapy on day 11. And in this way, you can see that we really did not produce a myelosuppression signal. As you can see here, the inter-cycle time between day 1 of cycle 1 to cycle 2, cycle 2 to cycle 3, etc., median time about 4 to 5 weeks, no progressive increase, and the proportion of patients with, I guess, longer than we would like duration between the cycles are acceptable. And so perhaps this way of combining triplets is the way to go. Did it produce a good result? Early follow-up, but as you can see here, again, for older people with a median age above 75, to have a non-adverse survival curve looking like this is obviously a very good start, and hopefully we'll have more updated data in the next presentation at ASH. So last of all, I just wanted to finish on this new concept of how we might treat patients with AML in the future. That is, often we know that there's a lot of clonal heterogeneity, a lot of plasticity with respect to AML, and often we wait until patients have morphologic failure before starting treatments. And most phase 1 studies are done in this really difficult setting of relapsed refractory disease. But with the advent of MRD, and as you can see, the potential to detect patients with impending relapse by a rising MRD, clearly the question should be, why don't we treat earlier? Why do we wait until patients have 80% blasts before coming in with new therapy? With respect to what new therapy to use, well, we know that NPM1 mutant AML, when exposed to single agent venetoclax, you can see here after just 7 days of therapy, more than half the patients have a more than 50% blast reduction just from venetoclax on its own. And so based upon this and the knowledge that NPM1 is a beautiful MRD marker where we can detect rising MRD about 3 or 4 months before clinical relapse, why not do a study of venetoclax-based therapy against rising NPM1 MRD? And so we did that. And so this is early data showing 2 groups of patients, either MRD relapse defined by a log increase confirmed with a subsequent test on the same tissue, or oligoblastic relapse, which is defined as 5 to 15% blasts, because in these patients, we just didn't pick up the MRD relapse with our 3-monthly interval monitoring. You can see that in the oligoblastic group with 5 to 15% blasts, CR, CRI, 83% with low-dose RSC plus venetoclax. With respect to MRD clearance of NPM1 by highly sensitive RT-qPCR, you can see in the MRD relapse group, CR negativity with our MRD negativity was achieved in 2/3 of patients. And you can see here, after just 1 cycle of therapy, 50% of patients have had at least a log reduction with 2 to 3 logs reduction, and also MRD clearance in some patients, which you can see increases to the plateau of about 2/3 by about the 4th cycle of therapy. In the oligoblastic group, you can see slightly lower rates of MRD clearance compared to treating earlier. And so the key question is, does this translate into better quality remissions with more MRD negativity, and better quality MRD negativity translate into improved progression-free and overall survival? Well, we don't know the answer just yet. However, you can see relapse-free and overall survival for the MRD failure intervention group versus the early morphologic relapse group. You can see here, too early to tell, but certainly looking very intriguing for the possibility that that hypothesis might be true. And so with that, hopefully there was some interesting aspects of hematology and AML at ASH, and happy to take any questions. Thank you for your attention.
Thank you. Am I live? Thank you very much, Andrew, for a nice presentation. Let me introduce you to Dr. Lau Zhen Tang. He's from Singapore, and he's also our APLC registry and repository co-lead. He'll be helping me moderate the Q&A session with Andrew.
Hi, Prof. Hi, Prof. Weeks. Yeah, excellent talk. Can I just start off with a question? would you recommend, in view of the data for poor risk AML patients, would you recommend, initiating it even in younger patients with very poor risk karyotype? For example, even things like inversion 3-3, that kind of thing, where they hardly respond to chemotherapy at all.
It is an intriguing question. At this stage, there's obviously no evidence to support the use of Ven/Aza in younger people, let alone younger people with adverse risk. However, I think the goal in younger people with adverse risk is still an allogeneic transplant. And so the question is how to get patients to transplant in the highest rate of remission possible. I think the answer to your question would have to be a randomized trial at this stage of, say, 7 and 3 versus Ven/Aza, or one of those novel triplets that I mentioned, in patients with poor risk cytogenetics, done perhaps without an age barrier, because I think all age groups really suffer from poor outcomes despite intensive chemotherapy. So as much as I'd love to say that these new therapies work, I think the right answer is what I've given.
So if you were given a choice to run a phase 3 study based on a triplet, any combination, what would be your dream combination?
Look, for
frontline AML.
Mutant AML, there's a number of possibilities. Perhaps the one with the most runs on the board at the moment would be magrolimab Ven/Aza. Obviously, we were all very hopeful that APR-246 might do something, but in the randomized study in MDS, there was no benefit in terms of CR. Obviously, other studies are in progress. We know biologically that targeting BCL2 and MCL1 simultaneously is quite effective for P53 mutant disease, and it would be lovely to see like a Ven/Aza plus MCL1 inhibitor triplet being developed. However, we're still in the phase 1 stages of MCL1 inhibitor evolution. And lastly, I think there are possibilities of immunotherapy perhaps having promise in the P53 mutant subgroup, in terms of which immunotherapy. The TIM3 inhibitor is looking interesting in MDS. So with P53 mutant disease in MDS, response rate 71%, with median duration almost 2 years. But whether that will translate into more advanced studies remains to be seen.
Do we have any other questions from the audience? Let me see. I think one of the more popular question is if basically, I think they're just wondering if we replace oral azacitidine with subcutaneous azacitidine, would you, in your opinion, would you see the same kind of response for AML?
So far, we haven't observed that. So there were 2 major randomized maintenance studies using subcut AZA. One done by Alan Burnett in the UK, and the second one done by the Hovon group. And both were in fact negative for survival. And so why is there a difference between oral AZA and subcut AZA? The first thing is that the schedules are obviously different. So one is given for 14 days, one is given for 7 days. One is oral, where the ease of delivering multiple cycles of therapy. In fact, at 2 years, 1/3 of patients were still taking oral AZA, whereas most studies using subcut AZA usually deliver 12 cycles or less. And so maybe it's the duration of drug exposure per cycle, the duration of exposure over time, as well as the different pharmacokinetics. If you look at the gene expression profile of subcut AZA versus oral AZA, the gene expression alterations with respect to methylation alterations are not the same. And the bioavailability of oral AZA is much lower than that of subcut AZA. So they're not the same drug, and obviously the delivery is quite different. Whether that's enough to explain all the differences, we can only speculate.
I think Prof. Ho from Taiwan was wondering about, what was this question? The role of total therapy. I think in AML, like multiple myeloma, I guess what he meant is like intensive combination followed by bone marrow transplant. Is that what you mean by total therapy? Maybe he can clarify the question. So.
Yeah, it's always tempting to go harder in AML. I'm not entirely sure if that will necessarily be the approach, because AML has this tenacious habit of evolving resistance to whatever we throw at it. So I think understanding the biology is really important. Targeting what we think is driving the disease. Transplantation still remains, a core aspect of cure. And in older patients where we can't deliver transplant, perhaps looking at the option of either sequenced therapy or serial monitoring and tailoring of therapy according to whatever's evolving at the time of the disease. I think those things remain core for older patients, because preservation of quality of life and not trying to basically obliterate the patient at the same time as we're trying to obliterate the disease still remain important principles of care.
I think we have a question from Prof. Go. I think with regards to the lacewing study, I think
I can ask you since I'm here.
Yeah.
So the negative effect of the lacewing study, is it due to the trial design flaw, which they crossover and the group, or is it due to biology, newly diagnosed AML being a polyclonal disease, or a factor of both?
Yes, so I think that study is telling us something. So when we treat with gilteritinib in relapsed and refractory disease, I think we have a much more FLT3 dependent situation. Whereas in the frontline setting, particularly in older patients where there's much more genomic complexity, many co-mutations, maybe FLT3 is not the driving force at the beginning of therapy. Interestingly, a sub-analysis of the lacewing study did divide patients into high allelic FLT3 ratio versus low. And interestingly, the survival curve definitely split much more in the high ratio group, sort of suggesting that possibility. Whether it's because we're not targeting enough things actively enough in the frontline setting, that's what the triplet studies are seeking to address. So Ven/Aza, where we're getting a response rate of almost 70% with FLT3, but we know that Ven/Aza, the most important cause of relapse in that setting, is in fact FLT3 mutation. If we target it, we know that there's synergy between gilteritinib and venetoclax. Maybe that approach will bear fruit, and the early signs are very promising. So we'll wait and see what the randomized data shows.
Let me see here. So one of our anonymous audience asked, is there a role for repeated cycles of ramped up regime for venetoclax in patients who are not in remission? I guess dose intensification probably is what he meant. Yeah.
Yes, with respect to Ven/Aza and remission, we know that 75% of people achieve a response after just one cycle of therapy. And after about 3 to 4 cycles of therapy, 90% of people have ultimately achieved their response. Therefore, if I don't have a response after about 3, maybe 4 cycles of therapy, I tend to move. Should we increase the dose of venetoclax? Although it's tempting, I don't think that will change the situation much, because we know that if we increase the dose of Ven to 800 or even 1200 milligrams when we did the dose finding studies, what we do is we produce almost unacceptable myelosuppression and inability to deliver more than 1 or 2 cycles of therapy. So I think new agents in combination, perhaps the way to go, potentially looking at reduced intensity transplant if we can achieve a good remission, again, as a way of trying to bring in the role of immunotherapy, and possibly using a more sophisticated approach such as triplets, built in with respect to 2 phases, the first half and the second half, rather than piling all drugs on top of one another from day one.
Maybe we do the question on MRD since
Yeah,
we
so
not tackled. Yeah.
Yes, so I was going to that also. So yeah, I think some anonymous person asked for, I think specifically for AML, that doesn't have a subtype defining marker, what kind of MRD modality would you recommend, and what kind of time points also?
Yeah, so in AML, it's unfortunately much more complicated than other diseases. And in fact, in Australia, where our whole program at the moment for the next 10 years is going to be focused on targeting MRD. MRD post-intensive therapy, MRD post-non-intensive therapy, rising MRD prior to clinical relapse, MRD post-transplant, because we just feel that targeting MRD is just the right way to go rather than targeting, frank relapse refractory disease. So we're using a hierarchy of markers. So we use the most specific and accurate markers like NPM1, markers for CBF, markers for MLL fusions. When we can't have access to those almost very specific markers, we use other more exploratory markers like FLT3-ITD with respect to FLT3 inhibition, and also IDH1 or 2, as long as we exclude pre-leukemic abnormalities. If we don't have a targeted marker, then obviously we use flow, and we're using two forms of flow: the conventional multi-parameter flow cytometry for leukemia aberrant immunophenotype, or just different from normal. And we also try to incorporate the new HOVON leukemic stem cell assay, which potentially can identify MRD, which MFC doesn't detect. So I think we need a package of therapy. I think the possibilities for NGS-based approaches with error-corrected sequencing and also duplex sequencing, which potentially gives us the possibility of looking for disease down to 10 to the -6, is very promising. And lastly, what I think may be the really most important aspect of MRD in the future is incorporating single cell sequencing into the clinical setting, because then we'll have a much better appreciation of clonal structure, gene-gene interactions, and how to really deliver precision therapy based upon high quality information. We just don't quite have that at the moment with bulk sequencing.
I think just in addition to the question also, we do see a lot of mutations that are duplicated in clonal hematopoiesis. So in AML, I'm sure quite a large number of patients with methylation or chromatin modifier type mutations have an underlying chip. Do you have any insight on how do we differentiate that, residual chip versus a real AML clone?
Yes, so what you can do is you can repeat the analysis in remission. So if it's an AML specific clone, then usually like FLT3, the level of FLT3 goes down in remission. Whereas if it remains high, then clearly it's a pre-leukemic abnormality. So that's the simplest way of distinguishing, pre-leukemic from leukemic, and also potentially germline abnormalities such as P53, RUNX1 in some cases.
Okay, I think time is about up. We realize that we're slightly overhead of time, but I think it leaves me now to thank both Andrews for really excellent presentations today, and thank the very audience for a great turnout. We really exceeded our attendances expectations. So in summary, you've seen that there's a lot of new changes for DLBCL. Prof. Andrew Davis have shown us that for our CHOP plus X, for the longest time, X has been the graveyard for many drugs that to come. And now we have very new exciting ADCs, we have new molecules, we have CAR-T, and we have new biological stratified approaches, such that X becomes really practicable. However, in Asia Pacific, access to drugs remain a problem. Polatuzumab is really expensive, not that cheap, and we know that access sometimes can be a problem and there are cost limitations. So we need to know how the best way to use it in the local Asia Pac context. For AML, Prof. Andrew Wei has mentioned that for the longest time, again, for AML, there's really nothing much new. And in a slew of the recent few years, we have so many new compounds. And this year, Ash, we heard of the CD47 magrolimab, and then maybe the compound for Trillium, there's a little bit. And then also we have the menin inhibitors with new ways of using drugs and so forth. So I think these are really exciting times. in our APLC, we hope to actually focus on the needs for the Asia Pac. What are the local biology like? What are the local limitations like? Access to drugs like? And then we hope to hopefully be able to lobby and bring some of these drugs and access to us in terms of trials, in terms of access programs, and in terms of outreach to our patients. So it's a work in progress. We hope to hear from more, to actually formulate this more together, and you'll hear from us again in the near future with new educational webinars as well as our symposium. So with this, I'd like to thank all our sponsors at VMGen and Roche, as well both speakers, all the audiences for their time for this evening to join us, and everyone else. Thank you very much. Goodbye.